Hello, welcome to AETCM, the Emergency Medicine channel. Today for the case discussion, we have with us Dr. Major Arun Wilson, who is a hepatologist at Amrita Institute of Medical Sciences, and our PG Karthiani will be presenting the case. Over to Karthiani.
Shall we begin, sir?
Yeah, sure.
A 58-year-old male was brought to ER with complaints of one episode of hematemesis since like 1 day. So initial 10-second assessment, patient was conscious, oriented and obeying commands, and he was speaking relevantly in full sentence. We went to the primary survey. His airway was patent. There was no pooling of secretion, no hoarseness of voice, no gurgling sound, and there was no evidence of any airway compromise. We went to the breathing. He was maintaining a saturation of 98% in room air with a respiratory rate of 20 per minute, and he had bilateral chest excursions were adequate. Air entry was bilaterally equal, and there was no signs of any aspiration, no crepitations, no wheeze. We went to the circulation part. Patient was maintaining a blood pressure of 108 by 70 millimeters of mercury, and he had a heart rate of 102 beats per minute. In view of the history of hematemesis, we had secured 2 large bore IV cannulas at this time. We went to the disability part. Patient had a GCS of 15/15 and had a GRBS of 96 milligram per deciliter. And coming to exposure part, patient temperature, he was febrile, and hypothermia was prevented by providing a warm blanket.
Okay. At this point, do we have any warning signs?
His heart rate is 102 per minute, sir. So there's a tachycardia. So he's not in a he's in an early hypotension maybe. So tachycardia may be a response to that.
Yeah. Karthiani, how did you know whether the patient is having hemoptysis versus hematemesis? From history, how do you know whether it is? Patient may say, coughing up of blood. Also, patient may complain of vomitus. So, how do you differentiate from a history whether it is hemoptysis versus hematemesis? Because management is different, right?
So, like this case, he was giving history of like a large volume of blood being like vomited out.
Okay.
Hemoptysis mostly like the history will be history of cough, like then history of if it is a TB and all, history of weight loss, fever, all those things.
Yeah. So there may be antecedent history which will suggest whether it is a hemoptysis or hematemesis. So if he is a CLD, if he is a NSAID intake and all those, you can see that you can think in terms of hematemesis. If the patient is having cough precedent to the thing, you can say that it is hemoptysis. And hemoptysis is usually brisk and small quantity, but large quantity hemoptysis can also occur. So from this history, from your initial screening history, what do you think is the likely source of bleed in this patient?
From the initial assessment, we know that he has got a probable hematemesis itself because of the large volume bleed, and he is going into maybe a shock because of a early tachycardia is there, or it may be because of some other cause, anxiety or anything may be there. We only after our further examination.
You can go ahead.
History. So at this point, we had taken a venous blood gas. Our venous blood gas, we come to know the acid-base thing, lactate, and also hemoglobin will also be there. So he had a pH of 7.408 with a bicarb of 24 and BCO2 of 39.5 and a lactate of 2.3. And hemoglobin was 12.8, sir.
Okay.
In this, his lactate is slightly getting elevated, but it is not like very alarmingly high.
So Sabha, do you think this is a significant bleed from his HB and this thing?
So for this to be called as a hemoglobin, sometimes when there's a massive loss of hemoglobin, then there can be hemoconcentration.
Yeah, that may be spurious. And secondly, the patient can have 17 hemoglobin, and he had a bout of vomiting, lost 5, and he's come to 12. So just don't go by the initial hemoglobin value, right? Okay, and he has tachycardia, he has got low baseline BP and rising lactate. So in this patient, you should suspect significant bleed. Okay, yeah, go ahead.
That was the adjunct we done after the primary assessment, and we had gone to the secondary survey and the history. So basically, coming to the sample history, patient has previously known non-comorbidities. He was not on any chronic medication. He is a chronic alcoholic and a smoker. Like day-to-day basis, he is taking alcohol and and a chronic smoker, and like he was told to have some liver disease, but he had never evaluated, never done anything in the past.
Okay. In history, it's better not to mention the patient as an alcoholic. You can just quantify alcoholism. It's kind of a stigma test. So you can say he consumes alcohol in significant amounts. So that brings us to the question, what is significant alcohol consumption?
Basically, it's the alcoholism cycling daily life, like daily routine life.
That's harmful drinking. So what is significant or what is detrimental use of alcohol?
More than 14
Units.
In
Ounces.
female and 21 units in male. Over a 10-year period can lead to adverse effects like cirrhosis, right? Next. So always don't mention he's a chronic alcoholic. Just say that he consumes significant alcohol. Okay. Yeah.
Then coming to like a medical history and allergic history, he is not on any medications, and he is not allergic to any like he has no non-allergies.
Okay.
So coming to the his events that has led to the current event situation. So patient had complaints of some fatigue for the last few days, and like today he had one episode of hematemesis at home. Clothes were there along with fresh blood, and according to the patient it was like around half liter. Then patient following that, patient was like taken to a local hospital. From there, like an RT was inserted and some medications was given and referred here for further management. And on the way, like he had 2 more episodes of hematemesis, and like but he had like no complaints of any like melena or other bleeding manifestations, no complaints of altered mentation, breathlessness, fever, abdominal pain, reduced urine output, and no history of any syncope, loss of consciousness, anything.
Okay. So one other question you should have asked is, did he have any multiple retching before hematemesis? Why is that important? Sabha?
There is retching, then there can be a tear in the esophageal mucosa like Mallory Weiss, and that also patient just vomits blood. And
That's also very common. So all bleeding in a cirrhotic need not be varical bleed. So that brings us to another question. How do you differentiate between a varical and a non-varical bleed from history? So you have to quickly assess because management is different, right? So Sabha, can you tell us how you differentiate between a varical and a non-varical hemorrhage?
So if it is non-varical hemorrhage, then it can be just a tear, like I said.
No. I'm not asking the etiologies. I'm asking from history, from labs, from this thing. How do you differentiate? You see a patient, with certainty. How can you say that? With certain degree of certainty, how can you say that this patient can likely have a varical bleed and this patient is most likely having a non-varical bleed?
It will have an associated CLD features, and it will be more in the
Okay.
lines of
So significant alcohol consumption. Then
either be abdominal distension, ascites can also.
So other decompensations, if present, more likely to have a varical bleed. Then
Large bout of bleed.
Large bout of fresh bleed. Especially red color flesh bleed is generally esophageal varical or gastric varical bleed. And generally, if you see non-varical bleed, peptic ulcer bleed, they are usually coffee ground. So they have significant contact with the acid hematin. So they are altered blood. And varical bleed is usually fresh blood. Then you can see on clinical examination, you can see signs of CLD. You can find and in non-varical bleed, you can have history of NSAID intake. Patient can be a CAD, a GRD patient, patient taking antiplatelet drugs. Then anything else, and then retching, all of this, right? Okay, so that's how in clinical history you differentiate. Okay, proceed.
This was the sample history, and coming to system-wise examination, patient per abdomen was soft and non-tender. There was no significant distension. Then coming to like CVS examination, chest examination, air entry was bilaterally equal and chest was clear. There was no evidence of any aspiration. CVS examination and CNS examination were within normal limit. Like in CNS, there was no flaps also, and even in general examination, there there was no significant pallor or edema or icterus noticed.
Okay.
So basically, system examinations were rather within normal limits. After the initial assessment and like after the secondary assessment, we again reassessed the primary survey. So his airway breathing was maintaining and his circulation also was maintaining like around 110/70. This BP was maintained, and heart rate was like around 100. 90 to 100, he was maintaining the heart rate, and disability, he was still having a GCS of 15/15, and there was no other compromise in the primary assessment.
Okay.
So we went ahead with the further our investigations and the further management.
Okay, proceed ahead.
Like while we had secured the cannula, we had taken blood samples for a complete blood count, the clotting parameters like INR, bleeding parameters INR, APTT, and RFT, LFT, and the serum electrolytes were taken. And like since he had given a significant history of hematemesis, since lactate everything is like slightly increasing with the background of tachycardia, we had arranged for blood products, like because it is high likely that he can require a blood transfusion. So we had sent blood for blood grouping, cross matching, and to arrange for the blood products.
What products do you arrange in a patient?
Sir,
how much should you arrange?
Sir, yeah, it is like this can be taken like any other hemorrhagic shock itself, sir. So if it is going into significant bleed, we will have to initiate an MTP. So like we need like PRBCs, platelet, and FFP. All the three should be like ideally arranged.
Is there any way where you can kind of restrict the use of your MTP protocol? Is there any bedside test that you know of that has been increasingly applied? Yeah, so you can use thromboelastography or ROTAM. So in a due course of maybe 3-4 years, you would need to know the interpretation of ROTAM and TEG, and I'm sure that you would be actually using it in our center here. So so these are tests to determine what component, and so that you can give directed. Okay, so since we are leading with a cirrhotic, so cirrhotic resuscitation is quite different from a peptic ulcer bleed. So this multiple transfusion protocol that you may use may be fraught with risk. So do you know any data or any trial which is told that which is better, whether it's a restrictive fluid blood transfusion strategy or a liberal transfusion strategy is better in a cirrhotic? Do you know of any data?
Basically, we like keep a target of around 7 for the cirrhotic.
That's based on
basically this critically ill patients, strict trial, and all like we keep it like.
So earlier we used what is known as a liberal transfusion. Everybody used to transfuse a lot, but then there was this trial published in NEJM. I think you must all go through it. So it's by Candid Villanova. So they did what is known as a liberal transfusion and a restrictive transfusion. So restrictive transfusion, they initiated transfusion only at 7 grams hemoglobin, and they maintained a target of 7 to 9. And the liberal group, they gave 9 as the starting point, and then they tried to achieve 9 to 11. And it was found that in CTP A and B patients, the people who were given a liberal transfusion had more mortality, not in child C. So you need to read this trial. So basically, why I put up this question is we need to know you need to know some target, especially in an emergency setting. You always treat to a target, right? So the target would be lesser than, and another caveat is that in patients with CAD, on these patients we may have a higher target, right? Okay, continue.
And other thing was by the time we had also started the patient on like a certain drugs. One is,
so what are the drugs that so you put in 2 cannulas, great. You asked for blood, great. So then you initially gave him fluids. What next?
Fluids, sir, actually we had not started him much on fluids because right now though like his BP is maintaining and there is like if we are going for a larger volume of fluid bolus and all, there is a chance of hemodilution worsening the coagulation and all.
But the patient has already told you that the patient has had 3 bouts of vomiting. 1 was half liter and 2 others which you are not quantified. So wouldn't you start a fluid?
So
You would, right?
Yeah, basically.
Awaiting blood, you would.
Maintenance of fluid, only
Yeah.
fluid bolus we won't be giving.
So in this patient, since the hypotension is not very marked, maybe you can start him on fluid and you have to reassess. So what are the methods to, in your ED, what are the methods to test for fluid, responsiveness?
One is if it is a fluid responsiveness, we can go for a passive leg raising test.
Yeah, very good. Passive leg raising is a very sensitive test. Then
we can check for the IVC collapsibility index.
Yeah, if you have an ultrasound, definitely you should look for the IVC.
Collapsibility index.
So if IVC is collapsed and all, then there is no point. You have to resuscitate. The capillary refill time,
the urine output,
peripheries, urine output,
lactate clearance.
Lactate clearance. So lactate you have already have, which is high, right? So these patients you must give fluid. Okay. While awaiting blood, also you must give some kind of fluid, because the patient might be bleeding internally, which you may not know. It may be obvious after some time. Like you said that there was no melena in this patient.
No.
So Binu, how much time does it take for melena to manifest in a patient with UGI bleed?
24 hours.
So generally it requires blood contact with acid hematine of at least 6 to 8 hours, and there should be a minimum of 50 ml of blood for melena to happen. So fresh bleed may not have melena, and very brisk hemorrhage, very large volume bleed may have fresh blood in stools. It may not have melena, right? So these are the things. So what are the drugs? So when now you have kind of confidently said that this patient is more likely having a varicose bleed, right? You're all with me, right? So in a varicose bleed, what are the drugs that you start?
Octreotide. You start with either
Proton pump inhibitors we can start. So.
We will start or we can start? We will start. So what is the dose of proton pump inhibitors and how does it help?
Our center we start on pantoprazole, sir.
What is the dose you will use?
We'll 80 milligram start dose and followed by an infusion. We usually
what is the dose of the infusion?
8 milligram per hour.
So if you can give, if you don't have the infusion pumps, you can give it as
boluses.
4 to 6 hourly boluses as well. So PPI, good. So PPI does not have real data actually in use in varicose bleed, but
ulcer bleeds it is.
We kind of extrapolate ulcer bleed data and use it in PPI. So PPI is one. Second?
Octreotide.
Okay. So somatostatin. So can Binu tell me what is the mechanism of action of octreotide? How does?
Somatostatin analog.
So what does it do?
Especially in case of cirrhotic liver and
Splanchnic vasoconstriction.
Yeah, it causes splanchnic vasoconstriction.
Then reduces the blood flow to the gastric mucosa and the esophageal mucosa.
Okay.
So further it reduces the bleed.
Yeah. So what do guidelines recommend? Do guidelines recommend octreotide or something else? So terlipressin. So Western guidelines recommend terlipressin as a first drug. But why are we using octreotide?
Financial, the cost.
Cost, yes, definitely cost is one major factor. So around 5 to 6 times the cost. But if you see the outcomes, terlipressin has got better efficacy in controlling bleed than octreotide. So what are the things that you check before giving a patient terlipressin? So any patient whom you are planning to give terlipressin, what all do you check?
Basically, terlipressin is arrhythmogenic.
So patients can have bradyarrhythmias. So you should have a baseline ECG before you start. Yeah, and you see whether there are any bradyarrhythmias and any evidence of coronary artery disease. One. Second,
hypertension. If the patient is like having a very high BP, like terlipressin.
Yeah, so that's okay. Third is any patient has got any peripheral arterial disease. This cause intense vasoconstriction and may cause limb losing, limb ischemia. Fourth, and a very lesser side effect is severe hyponatremia, because this has got what is a kind of an ADH action, so may cause hyponatremia. So you basically screen for bradyarrhythmias and ischemic heart disease before you start terlipressin. What is the recommended dose of terlipressin in bleed?
3
it's usually you give 2 mg every 6th hourly till bleed is controlled, or up to 48 hours, whichever comes first. Like you initially start the patient on 2 mg 6th hourly, 4 to 6th hourly, and then once the bleed is controlled, you can convert into 1 mg 6th-hourly for a total duration of 5 days. So that is the dose of terlipressin. Okay.
And octreotide dose?
Octreotide like
Octreotide?
50 to 100 microgram stat, followed by like infusion of 25 to 50 microgram per
So
hour.
it's 50 to 100 stat followed by 50 mics per hour. Okay. Until how long will you give?
Again, like after bleed is controlled, like maybe
Yeah,
like
up
after
to
endoscopy.
or up to 5 days time, because all of these drugs have tachyphylaxis. After that, it really never works. Right?
120 hours, like if no rebleed is there, we can.
Yeah. So, okay.
And
Proceed.
remember that all three things, pantoprazole, terlipressin, or octreotide, whatever we have told is pre-endoscopy doses.
Yeah.
So based upon the endoscopy, things might change.
Yeah.
That might.
Yeah. So when do you call your gastro colleagues?
Yeah, sir. Like once a patient is stable, like if the primary assessment is like fine, and after the history, like we know that this requires intervention, we can get a consult. Like
Is there any optimal time for calling for endoscopy?
early endoscopy is like better within 6. If it is like patient is stable, within 6 to 12 hours, and
What do you say, Binu? Do you have any difference of opinion from your?
The usual guidance used to be like within 24 hours.
It's 12 hours. So you can, now what guidelines say is 12 hours. But you must remember that these guidelines are written for general practice in resource limited settings as well. So if you have a patient in your emergency who's bleeding profusely, uncontrolled, so you will not wait for 12 hours, right? So if you have the expertise, you may have to call in them early, right? But if the patient is okay, stabilize. So the stabilizing the patient takes precedence. Yeah, that should be first, because patient may collapse during endoscopy, patient may require intubation. So you have to make the candidate an ideal. If the patient is in, most of these alcoholic patients may be in withdrawal, they may be agitated. So doing an endoscopy is fraught with risk, right? So those kind of stabilization, if these things have to be managed, they have to be managed first before you call an endoscopy. But if a patient is actively bleeding in the hospital, you will not wait for 12 hours, right? Got it? Okay, so that will be, yeah. So the other thing is, do you put in a Riles tube in all cases of bleed?
no.
What is the practice? Should you put a Riles tube?
Ideally, endoscopy guided is like better. Like if it is actively bleeding, we usually don't put.
Yeah. So if it's actively bleeding, you may push in a Riles tube. It can kind of injure another varix rupture. So if it's an active bleed, there is no. But if the patient is giving a remote history of bleed, and you want to call in an endoscopy, your HB and all is stable, you should not be, sitting assured saying that the patient is not bleeding, whereby he may be bleeding internally. In those cases, you can put in a Riles tube and give a lavage. Okay. So otherwise, that's the only indication. If the patient is actively bled and you have the signs of bleed, then there is no point in putting a Riles tube. Okay.
Basically, suspicion of varices is not a contraindication for Riles tube.
Yeah.
You can
put
the Riles tube.
Yeah. Okay. Then
But I think post EVL probably.
we will. That will come to. I've kept it as another question. Okay. So now you've called your gastro colleagues. So so the patient is bled. So the problem with when we do endoscopy is that patient is not adequately prepared, right? So patient might have recent. The one important thing is to keep all these patients NPO.
and
So that will facilitate so any prokinetic dose you will give drug.
Metoclopramide 10 milligram.
Yeah, so you can give perinom or you can give erythromycin as well for preparing. So at least 4 to 6 hours of NPO is required for the endoscopy. So you're doing the endoscopy.
And one more thing, sir, antibiotics also like.
Yeah, very important question. I had written it down, I forgot. So what is the role of antibiotics in a varicella bleed? Do you know any study or any data to suggest that you should use antibiotics? If so, what antibiotic would you give?
So we can give like
you can give ceftriaxone.
Or we maybe fluoroquine
Great answer. Okay, so she's put invited another question. So you have both fluoroquinolone available and you have ceftriaxone available. So what do you give and why do you give and for how long do you give antibiotic?
Blood is a medium for bacterial growth, and the CLD people will be immunocompromised. So like they are more and there will be like gut bacterial
Okay, so more than blood being a medium for gut is relatively sterile, right? So it is not actually due to blood being a medium that you give antibiotic. There is, because when the patient bleeds, what happens is that there is tissue ischemia. When there is ischemia, there is break-in barrier. When there is break-in barrier, there is increased gut translocation of bacteria and you may have infections. Okay, so it is found that if you give patients have around 26 to 40% chance of infection after a bout of hematemesis, so you give antibiotics. Now the decision is what antibiotic to choose. You have all antibiotic available in a center like ours, so what do we choose? So basically you need to see the patient's clinical status. If the patient is having recent patient was on fluoroquinolone prophylaxis, like he is taking norfloxacin for SBP prevention, or then there is no point in giving a fluoroquinolone. Those cases you give ceftriaxone. CTP-C patients, again you give ceftriaxone. And in a patient who have had a past bleed, again ceftriaxone you prefer a parenteral one. If the patient is accepting orally and not been having anything, you can even go for a oral fluoroquinolone, but by and large the practice is to give a IV third generation cephalosporin. Okay, and till how many days do you give post bleed? So you should follow antibiotic stewardship, right? So once you started, how many days would you give an antibiotic to a patient with upper GI bleed?
5 to 7 days.
So you have to give up to 7 days, and parenteral till the time patient takes NPO. And after that, if clinical condition is settled, you can convert it into an oral antibiotic and continue for 7 days. That 7 days is to prevent SBP. Okay. So that's the antibiotic part. Now, supposing you may end up in centers after this where you don't have an endoscopic backup. So the patient is bleeding continuously, you have resuscitated initially, the patient is continuing to bleed and you don't have an endoscopy. So what do you do?
Sense-taken Blackmore tube.
Okay. How effective is sense-taken Blackmore tube?
And that's a tampon.
No. What is the effectiveness of?
Percentage, I'm not sure.
Okay, well, just take a guess now. Immediate control of bleed. So around 90% of bleed can be controlled. But the problem is that 50% of them will rebleed within 24 hours. Okay. So as an immediate temporizing measures, you can use like people like us who were like did our education a bit more senior. We are all fans of sense-taken Blackmore tube because we couldn't call in endoscopy at that time. So it was a norm. Have any of you tried putting a sense-taken? But you must try in one of the patients here because that's a skill that you need to have. You know any other tube like sense-taken Blackmore tube? Have you heard a name of another tube?
Anything starting with M?
Anything with M or anything with L? There's something known as a
Minnesota.
Lincoln Nichols tube, Linton Nichols tube, LN tube, that is there. That's also like that has an additional port. So today all of you should go and watch how to put it's there on YouTube, a good video is there on YouTube, how to insert a SB tube. So now
There's a Minnesota tube.
Yeah, there's a Minnesota as well. There is a how to insert an LN tube or and this is kept as your viva. One of your instrument identification is SB tube invariably. So you need to know that. Okay. Then now that you've called in the endoscopy. So you know how varices, the classification of varices, how do you say? I don't think that will be important for them, right? But
like basically there will be like some red nick like.
So okay, we'll come to that. Okay, so see the esophageal varices, you'll have columns. So when do we band is that we have something known as a recent stigmata of bleed. What are the recent stigmata of bleed? Sometimes they may be active bleed, maybe active spurters. Sometimes there might be what is known as a red cherry sign or red veil sign, or there might be a nipple or a white nipple or a red nipple. All of these are there. These people have very high chance of rebleed. So in these patients, we have what earlier we used to have banding versus sclerotherapy. Now banding is the standard of care. So we band. So we have band ligators and we ligated. So before that, the most important thing is that any patient, even if you see the esophageal varices, always we go inside and look for ectopic varices and gastric varices. So which do you think is more risky, gastric varices or esophageal varices?
Gastric virus.
So gastric varices will bleed at lower pressures, and their management is quite more challenging and technically difficult than esophageal varices, right? So you rule out other causes, you look at gastric varices. So gastric varices, do you know any classification of gastric varices?
Sarin.
Yeah, so there is something known as a Sarin's classification. Dr. Sarin is an Indian, so we should all be proud of that. So there is something known as a gastric varices. So in gastric varices, if there are esophageal varices and varices continuing towards the lesser curve, these are called as GOV1, gastroesophageal varices 1. If there are esophageal varices and varices continuing to the greater curve, which are the cardia and below the to the fundus, these are called as GOV2 varices. If you don't have esophageal varices and you just find gastric varices at the fundus, you call it as IGV1, isolated gastric. So in that case, technically speaking, you should not have esophageal varices, only gastric varices, then you call it as IGV1. And if it's anywhere else other than the fundus, you call it as IGV2. Okay, so gastric varices, just to complete the discussion, are initially what you do is you do injection sclerotherapy. You inject butacryl or endocryl, you inject into the varix. That is the because banding will cause ulcerations and rebleed. So in gastric varix, so gastric varix standard of care is glue injection, right? Okay, so for emergency medicine, I think you don't have to know the in depth of bleed management endoscopy, but it is nice to know that these are esophageal varices. The primary modality of management is banding and this thing. So what is the risk of rebleed? Do you have any scores to know what is the risk of rebleed in a patient with?
Rockel score we can check for that is, it has a pre-endoscopic and a post-endoscopic thing.
Is it basically for what kind of bleed, Rockel score? These are basically for
predicting.
Yeah, that's a rebleed risk. But most of these scores that we have currently are for ulcer bleeds, right? Your Forest classification, the other bleeds are all for usually for the non-Viricell bleed, right? So generally we can say that if a patient is CTPC, has got bilirubin more than 3, or if got significant ascites, or is come in HE with bleed, these people have got high rebleed risk within 5 days, high early rebleed. So you need to know what is early rebleed, what is late rebleed. So when do you define a rebleed? So patient
120 hours of the first procedure,
if the patient has got hypotension, you should assume that the patient, if there is 3 gram fall in hemoglobin or a 9% fall in hematocrit, or continuing to have shock, so these people, or there is 100 ml of fresh blood in RT, aspirate. So these people are, you have to say that these are early rebleed. So now we have done medical management, you've done endoscopic management. Again, patient continues to bleed. So what do you do?
Then, sir, angio any
So
IR.
the first step is to do a second attempt at endoscopy. Okay, if the second attempt of endoscopy is failing, so what do you do?
Interventional radiology or a surgical, both the things we have, angioembolization,
So have you heard about something known as TIPS?
Yes, sir.
TIPS. What is the full form of TIPS, Sabha? Transhepatic intrajugular portosystemic shunt. So what do you basically do? We know that the portal pressures are high, right? So and because of cirrhosis, the liver is very firm and nodular, right? So we are kind of making a bypass from the portal vein, one of the branches, usually the right branch of portal vein, to the hepatic vein.
We are shunting blood from
so we are bypassing the hard liver. It's just like a roadblock is there, we take a bypass road, right? So we're shunting blood there. So so in which patients would you advise for a early TIPS? Early rebleed, endoscopically not controlled, then
ectopic varices, gastric varices, Then a patient having a hepatohydrothorax,
Okay. So basically, you will use in a patient whom endoscopically we know that there is, like I told you the previous condition, right? There is significant risk of rebleed, CTPC, patient in ACLF. These patients, we can do what is known as a preemptive tips, where we know. So what? So I'll come to one of the last questions. So what is the difference between rescue tips, salvage tips, and preemptive tips? So rescue tips is while you're at the second endoscopy, you know that the patient is continuously bleeding, you take the patient for after the second endoscopy is done, patient is not controlling to bleed, and as a last salvage measure you do, it is known as a salvage tips. Preemptive tips is you know that the patient has got risk factors like an ACLF patient, CTPC patient with active bleed. These are the CTPB with active bleed or CTPC with large varices. These patients, you know that if you put band and all, these people will develop posterior ulcers and bleed. So in these patients, we will it's kind of a prophylactic tips, preemptive tips. You preempt that the patient will bleed. Okay. Then what are the problems with banding?
banding, ulcers.
Yeah. So what actions you take after the patient? Now I've banded the patient and I've left. So what all are the other measures that you take for this patient? So what all drugs will you give after endoscopy?
PPS should be conducted.
For how many days?
PPS should be
Sabha? Expert comments. Huh? So at least for 14 days you continue PPI, and you should also give any sucralfate, ulcer protectants, ulcer healing protectants for 14 days. Okay, so sucramol or sucralfate, whatever you give it 15 ml QID for at least 14 days. And when should you call the patient back? Once banded is not away. So once you band a patient, when you call the patient back in your discharge patients, usually with bleed may come here, may not get admitted, mild bleeds, we may not have beds. We may discharge a few patients who are stable in the ER. So when do you call them to a gastroenterologist? So usually once a patient has bled, then it's better to do a relook endoscopy after 3 weeks. If the patient has not bled, to just see if the patient requires any follow-up banding or not. So the patient should ideally come back after 3 weeks. Okay.
Beta blockers.
Yeah. Then
prophylactic propranolol, carvedilol, all are
all are available. What do you give?
No, maybe some studies showing carvedilol is
Okay.
better.
So I'll tell you one thing. So there are primordial prevention, primary prevention, secondary prevention. Okay. So when the patient, so I'll just quickly sum up because we are already running short of time. So if a patient has never bled, and has got significant risk of varices, we did an endoscopy and we find that the patient has got significant varices, but this patient has never bled. So in these patients, you can either offer beta blocker or you can offer endoscopy. So the choice is patient's choice, the cost factor and local expertise. Both are equal. So where is it equal? In a patient who has never bled and has got significant varix with no stigmata of bleed, either beta blocker or this thing you can give, right? In a patient who has bled once, you should give both endoscopy and beta blocker. So you do endoscopy till the varices are eradicated and continue on beta blocker, right? And
we discussed about overt bleeds, right? In case of occult bleeds, is there any other investigation options available?
So the patient is only of Malina.
This maybe stool, occult blood, all these things.
Okay. That is showing. So we are evaluating.
Then
And scopy,
capsule
we are not able to-
enteroscopy can be done. That is
you
for.
can do capsule endoscopy as well.
Then if some angio can be done, even radiologically, angio can be done to look for any bleeding blood vessels or anything.
Anything nuclear?
Can you do any specific scans which can isolate source of bleed? When these are all you exhaust your endoscopic things, you do CT angiography, everything.
Technician.
All nuclear or technician? What technicians can? So there you can do a RBC scintigraphy scan. There's one. But the problem is that if there is only active ooze from somewhere, they will pick up. And it is a cumbersome test. It requires 24 hours, long-term imaging, multiple setting imaging and all. A bit difficult. But in very obscure cases, you may have to resort to that. So we'll just sum up. So what we've discussed today is from a patient's history, how to differentiate between a varicella and non-varicella bleed is very important. Then initially how to risk assess the patient, whether the patient will have rebleed, whether the patient is having significant bleed or not. Yeah. Then if it's a varicella hemorrhage, what are the investigations you send? How do you stabilize the patient? What is the blood transfusion strategy you use? What are the pre-endoscopy medications that you use? When do you call in an endoscopy? In endoscopy, what are the things that you expect? How do you deal with esophageal varices, gastric varices? Ulcer bleed is a different topic. We may have a different session. Then what is the follow-on advice do you give? How much of, when do you call for review? What all drugs do you give on discharge? What is the role of antibiotics? What antibiotics to choose when? And when do you stop the antibiotics? So I think we have kind of covered it.
Just for completion's sake, we will just assume that while we are waiting for around the patient have another massive bout of bleed and collapses.
Yeah.
From the resuscitation point of view, what are the key points? We need not go into the depth, but the key things which we need to keep in mind.
High chance of airway compromise.
Okay. So what will be the indications for intubation in such a patient?
Very important question.
Like large bout of bleed, like sensorium coming down.
Okay.
Then if like he is worsening of hypotension, impending an arrest, then if aspirated, like patient had large bout and he is aspirated, desaturation, all this is coming.
And at times to facilitate endoscopy itself.
Yeah. An agitated patient with active bleed, especially alcohol withdrawal patients, agitated patient, low GCS, encephalopathy. These patients may require an elective early intubation to facilitate endoscopy. Right?
From the drugs point of view, what all induction agents you think preferred over the other?
Sir, if there is like a significant hypotension, we can go for ketamine.
Okay.
Then or a safer, we can go for etomidate also, because it is stable. Hemodynamic instability won't be there. Then other thing is while we are doing the intubation, continuous suction will be required.
What's the method called?
Salad method, suction and assisted
Suction assisted laryngoscopy.
decontamination.
Yeah.
So we'll
And
have
position of the patient, preferably?
a bit propped up itself, sir. Like only while doing the scopy only we can, if required, bring him down.
So
Otherwise,
usually at 45 degrees with the head parallel to the roof is one of the methods which is being recommended. And that.
so that is one thing.
And regarding bag and mask ventilation?
We have to reduce it, sir, because one thing is we are giving in more air. That will worsen the distension. The sphincter tone will be low, so that will further increase the
So
bleed.
keep these concepts in mind. It doesn't mean that you need not bag and ventilate the patient, but keep these concepts in mind. And what is apneic ventilation?
Sir, we can put in a nasal prongs and continue oxygenation at 5 to 15 liter, so that even when there is no active amboing, there will be a flow gradient will be happening. So even if the patient is not taking in breath, since the oxygen is getting used up, there will be a flow difference and concentration difference, and so that oxygen will get in. So it will prevent the it will give more time for that desaturation to happen.
One last question I forgot to ask, because they asked, so endoscopy is done. Patient is still not out of HE and all. You have to facilitate feed. When will you put in a Ryle's tube? Very practical question, okay?
Along with that, endoscopy.
Yeah, so actually that's kind of a difficult practice, because we do an endoscopy, we put in a guide wire and put it at most times, but it entails a lot of cost, because you need another pediatric endoscope. You put in a guide wire, put it through the nose, pull it, railroading through the nose and all. But generally it is safe to put in a Ryle's tube 24 to 48 hours after endoscopy. So initial 24 hours, it is best not to kind of put in a Ryle's tube, okay? And better is if the patient is avoiding, to use a less traumatic kind of variant called as a fracas tube. You've heard about insert a fracas tube,
Yes.
will be less traumatic, right?
There's a guide where.
Yeah. Okay.
I think good.
Very well presented. All of you well answered. You must go and read back all these, right? Okay.
Thank
Thank you.